we can go to the next slide, please. All right, good morning and welcome to this public webinar on helping patients in addiction treatment stay connected during the COVID-19 pandemic, which has been jointly organized by the National Academy of Medicine and the American Society of Addiction Medicine. My name is Elizabeth Finkelman and I direct the National Academy of Medicine's Action Collaborative on Countering the U.S. Opioid Epidemic, which I will describe further in a minute. The Action Collaborative has benefited greatly from the participation and leadership of the American Society of Addiction Medicine, represented by Dr. Kelly Clark, and we are so pleased to be collaborating on this webinar together. Today's free 90-minute webinar will provide insights on issues of access to addiction treatment and targeted guidance on how to effectively keep patients connected during treatment during the COVID-19 pandemic. This webinar is the first in a series called Supporting People with Addiction During COVID-19, hosted by the National Academy of Medicine and the American Society for Addiction Medicine. Dates for future webinars in this series will be announced soon. Today's webinar has been approved for 1.5 hours of AMA PRA Category 1 credits and for 1.5 continuing education credits from NAADAC, the Association for Addiction Professionals. Please note that in order to claim credit and receive the certificate of completion, participants will need to complete the mandatory evaluation at the completion of this webinar. This webinar is being recorded and the video, along with presenter slides, will be posted on the NAM and ASAM websites after the event concludes. Next slide, please. Today's webinar will last 90 minutes and will follow the agenda you see on your screens. We'll begin with 10 minutes of introductory remarks provided by myself and Dr. Kelly Clark, who will be moderating today's discussion. We will then hear from our panel of speakers who will each speak for about 10 to 15 minutes each. We will then move into moderated discussion with the panel before opening it up to questions from the webinar audience. The webinar will conclude by 12:30 p.m. Eastern. Next slide, please. Questions and comments from the webinar audience can be submitted at any point during the webinar, and we will do our best to get to as many of them as we can before the webinar concludes. Please use your comment box on your screen to submit a question. Again, this webinar is being recorded, so please understand that any questions you submit may be read aloud and included in our recording. Next slide. We hope that you will join the conversation on social media and tweet over the course of the webinar using the hashtags COVID-19 SUD treatment and opioid collaborative. Next slide. Now I'm just going to spend a couple minutes providing an overview of the NAM's Action Collaborative on Countering the U.S. Opioid Epidemic. Next slide. So recognizing the need for a cohesive and collaborative response to the nation's opioid epidemic, the National Academy of Medicine established the Action Collaborative on Countering the U.S. Opioid Epidemic in 2018 as a public-private partnership to foster greater coordination and collective action across the health system and beyond in addressing the opioid addiction crisis. The Action Collaborative uses a systems approach to convene and catalyze public, private, and nonprofit stakeholders to develop, curate, and disseminate multi-sector solutions designed to reduce opioid misuse and improve outcomes for individuals, families, and communities affected by the opioid crisis. The Action Collaborative has 3 foundational goals that guide its work. The first is to identify and raise the visibility of complex challenges, outstanding gaps, and needs of the opioid crisis that require a collective multi-sectoral response. The second is to elevate and accelerate evidence-based multi-sectoral and interprofessional solutions to improve outcomes for those affected by the opioid crisis. And lastly, the Action Collaborative aims to catalyze action on shared priorities and solutions to help overcome the crisis and improve outcomes for all. The Action Collaborative's work is organized around 4 core priority areas, which represent among the highest priority elements of the nation's response to the opioid crisis. These include strengthening health professional education and training around substance use disorders and pain management, improving pain management guidelines and evidence standards, accelerating, sustaining, and scaling prevention, treatment, and recovery services, and elevating pressing research data and metrics needs. Around these areas, we are producing several policy and technical white papers, as well as webinars, public meetings, and a variety of dissemination activities. Next slide. Of course, with the emergence of the global COVID-19 pandemic earlier this year, the Action Collaborative is pivoting to focus on ways in which we can support the SUD and pain communities during this challenging time. As such, we're undertaking a series of activities to be responsive in the near and longer term. So first, we've created a resources page on the Action Collaborative website to collate and share emerging COVID-19 resources across the Action Collaborative's membership. We're conducting virtual town halls for the Action Collaborative members to share updates on ongoing efforts to address the impacts of COVID-19 on the OUD, SUD, and pain populations. And in the coming weeks, our steering committee of cross-sectoral leaders will be releasing a statement highlighting critical priorities and actions that need to be taken in the near term to protect the health and well-being of individuals with substance use disorders and pain in the context of COVID-19. We will also be highlighting pressing and immediate research priorities and needs, and of course, producing publications and conducting webinars such as these on high priority topics. I've only really scratched the surface of what the Action Collaborative's activities include, and so I encourage viewers to visit our website to learn more and to sign up for updates. So if we move to the next slide, I'm now pleased to introduce this terrific and talented group of experts whom you'll have the pleasure of hearing from today. Today's discussion will be moderated by Dr. Kelly Clark, who is the immediate past president of the American Society of Addiction Medicine. And joining Dr. Clark are Dr. Brian Hurley, who is the Director of Addiction Medicine at the Los Angeles County Department of Health Services, Dr. Chris Bundy, who is the Executive Medical Director of the Washington Physicians Health Program, and Ms. Courtney Lavelle, who is a recovery coach and co-founder of Our Wellness Collective. Viewers can download and read their impressive biographies on the webinar event homepage to learn more. And with that, I'm pleased to turn the presentation over to Dr. Kelly Clark. Thank you.
Thank you, Liz. Good morning, everyone. Thank you for joining us here today. Next slide, please. So what we're hoping that you will leave this webinar with, for those of you who do not have access to the visual right now, is that you'll be able to understand some of the and discuss the unique challenges to substance abuse treatment providers and to patients regarding care during the COVID-19 pandemic, recognize some patient-centered strategies for maintaining access to addiction treatment, identify recent changes to telehealth regulations, payment changes, clinical guidance related to access to medications and support groups in particular during this time, and be able to describe strategies to ensure patients remain connected with their providers for treatment, and also for peers for their recovery support during the pandemic. Next slide, please. As Liz mentioned, I am the immediate past president of ASAM and currently the vice chair of our COVID emergency task force. And we're attacking this almost chaotic environment right now during the pandemic with multiple prongs by obtaining and synthesizing and having input into the national and state guidance from a variety of stakeholder groups, through our task force itself to synthesize that and build new guidance for people in the field and for patients, and then coordinating a bidirectional flow of information through our chapters, because we have chapters in each state, and utilizing other information distribution networks that are bidirectional, like Project ECHO. If you have you'll see at the bottom is where you can go to see additional resources. You can also just Google ASAM and COVID, and that'll get you there. Next slide, please. The resource page will have a variety of information on it. Next slide, please. And just as an overview, again, for those of you who don't have access right now to video and are wondering what kinds of guidance might be up there, what we have built are guidance around infection mitigation in the outpatient setting and in the inpatient setting, guidance around delivering telehealth services, around adjusting drug treatment protocols, access to buprenorphine in outpatient settings and office-based settings, access to care in opioid treatment programs, support group guidance, guidance on medication dosage and formulation considerations unique under some of the constraints of the COVID-19 pandemic, and treating pregnant women with opiate use disorder. Next slide, please. And what's coming soon is guidance for addiction treatment and addiction patient care in general medical hospitals, in criminal justice populations, the homeless population, and clinician and physician well-being guidance as well in this stressful time. Next slide, please. There's a difference between guidance and guidelines. Guidelines are things that take a year or more and 6 figures or more to put together, that are very evidence-based, and go through a full stage of public approval. We are in a crisis situation here, and so what we are put together is guidance, a very rapid process developed by a few experts, vetted by a very distinguished review group, and quickly released and then reiterated as we get input from our provider members, our other clinicians, patients in the field, and other stakeholder groups. Next slide. And to get to some of the larger themes, before we get into some of the meat of this with our three panelists, one of the big underlying themes we've noticed is that clinicians and treatment programs and entire systems of healthcare and other systems of care must pivot during these times from sort of a traditional best practice method into a method that looks to where we're doing the best we can under the current situations with the current resources in that provider's community for their patients. So we're not in a situation where we have all the resources typically available. We're in a different situation, and the recognition of that and helping get information back and forth about what different clinicians are doing, different systems are doing, can help people react to the changing times that we're in. Next slide, please. The other, another theme that we've seen is very rapid and very deep federal guidance, changes in federal regulatory changes and payment changes throughout the federal government, but it has to be understood and then implemented at state and local levels in order to actually be something that clinicians and patients and payers and whole systems of care can take advantage of. The third theme is that there is an urgent, emergent need for all members of all of these systems to break away from the silos that we've traditionally been in and collaborate to build new systems of care that have not existed before in order to deal with the disruption of the pandemic. Next slide. So finally, the anticipated phases of the pandemic is something that we've been looking at. In the early phase, which is where most communities are now, there's a very low population prevalence so that we can prevent transmission of the virus using physical distancing. We can develop protocols for identifying and isolating individual patients and staff. But during that time, during that phase one, we must start planning for this next phase. So that we're prepared when it comes. That middle phase is when there's a higher population prevalence, which makes isolating individuals really impractical. When you've got 40%, 50% of your patient population, your healthcare population positive, we need to be looking at different levels, different kinds of systems, perhaps parallel systems of care, which we speak to in much of this guidance as well. And then finally, we will be working into our post-pandemic world where we update best practices based on the lessons learned. But since we're right now in most communities in the early phase, much of this guidance is around early phase work with a parallel coming into preparing for the middle phase. Next slide, please. So we'd like to hear from you. If you've got questions, if you've got best practices, if you've got something that's doing and working for you, if you've got something that's not working for you that you're doing, please email it to covid@asam.org. We're collating and utilizing this information to try to move guidance forward. So with that, I thank you for hanging in there through the overview of the work that we're doing, which will give you some sort of structural basis to hang some of this next information on. Next slide. So first, I would like to hand this over at this point to one of our the first of our three panelists, Dr. Brian Hurley. Dr. Hurley?
Hello, everybody. I'm Brian Hurley. I work as the Director of Addiction Medicine for the County of Los Angeles Department of Health Services, and I'm a Director at Large on the ASAM Board of Directors. Next slide. So what I was going to talk about for the next 15 or so minutes is to talk about how to connect patients to treatment, or people in the community to treatment during the coronavirus public health emergency. And the pandemic is, we expect to increase demand for addiction treatment. There's something stressful about sheltering at home, and one of the drivers of substance use disorders and really sort of stress in general is social isolation. And so we expect that stress, anxiety, isolation, stay-at-home orders, and border restrictions, as well as the economic fallout of the pandemic, is likely to make people more susceptible to emotional dysregulation, which makes it harder to manage triggers to avoid intoxicants. We expect that stay-at-home orders and border restrictions are likely to reduce the availability of both legal and illicit intoxicants, and then to increase symptoms of addiction and mental illness. So it's crucial that patients have access to treatment throughout the public health emergency. Next slide. So one way to connect patients to treatment is to bring treatment to where the patients are. And so, you know, we're, I don't know, 1,000 or so people connected across the United States using a telehealth, using an audiovisual platform. We can use platforms like this platform to bridge that gap with telehealth, right? So to continue patient engagement while minimizing in-person interactions. And that means rapidly converting programs that are typically done in person to telemedicine and telephone visits when possible, when feasible, right? There are some things that it's hard to draw labs, for example, when you're not physically in the presence of somebody. But whenever feasible to deliver care without an in-person visit, the coronavirus public health emergency has really emphasized the need for us to be able to deliver care and connect without necessarily being next to each other. And that means that anytime that a treatment provider is planning on bringing a patient in, that it needs to be contextualized to for that individual about whether the in-person visit is worth the risk. That is, each individual visit has their own sort of new risk-benefit calculation in the context of the coronavirus pandemic. Next slide. So Dr. Clark mentioned the ASAM coronavirus website, which is really just a whole bevy of resources. It would take me or others at ASAM probably a full 90 minutes just to go through everything that's there. Actually, probably take a full day. So I'm going to highlight just a few key resources that are important around telehealth guidance, as well as around extending treatment to the community throughout the pandemic. So there's a whole number of now federal policy changes that are in both Medicaid payment, in licensing, and in the enforcement of HIPAA rules on privacy regulations. And so these were largely changed in March and in early April, but these do evolve, right? The policy changes continue to shift. And so I would just refer everybody to the ASAM coronavirus pandemic website to be able to see the updated policy information about what CMS is doing, about what HHS is doing, generally doing around sort of privacy enforcement, about what SAMHSA is doing. That's all listed there. Next slide. So for providers, and I know, so I work as the director of addiction medicine for a large municipal health system. Our municipal health system is now faced with how do we deliver care without in-person visits. And so we've had the chance to sort of look at, well, what telehealth platforms are available and how can we deploy them. So this is a quick chart that goes through, there's what is called synchronous telehealth platforms, which are virtual audio. Telehealth typically refers to both audio and visual platforms between patients and providers. And so there's synchronous telehealth platforms, which are literally like what we're doing now, right? So you can see and hear the person who's talking, you can see and hear the patient. That would be an example of a synchronous audiovisual visit. There's also synchronous telehealth consultation. So providers, rather than necessarily needing to meet in person, can do audiovisual consultation. Project Echo is usually based out of this sort of synchronous telehealth style consultation, which is typically sort of webinar-based webinar style trainings or consultation. And then there's asynchronous visits. So there's e-visits where patients can put information, say, into a patient portal, and then providers can respond. And then there's e-consults, right, which is where a provider might ask a question to another provider, and then the other provider, through an e-consult platform, would provide information. Those are asynchronous platforms. And then there's truly sort of telephone care, which has no visual component, and it can be live, like scheduled telephone call where two people are talking on the phone, or asynchronous, which is typically through voicemail exchange. It's important to distinguish, though, that there's telehealth and then there's telephone, and they are regulated slightly differently, reimbursed differently. There's sort of different codes that many states are now rolling out, and CMS is requiring to sort of document telephone visits differently than telehealth or audiovisual visits, even though both are ways of delivering care without seeing patients in person. It is advisable that for individual practices that are seeking to do telehealth to contact their malpractice carrier, because oftentimes malpractice carriers have telehealth coverage, and policies need to be updated, and that's sort of a relevant tactical consideration. Next slide. So the COVID public health emergency, there's been a whole now really rapid change in the regulation of telehealth. So many states, and last I checked, I think it was I don't know, in the double digits of states have now submitted 1135 waivers to permit providers to offer telehealth services in essentially any healthcare setting. So previously, 1115 waiver, there was a lot of restrictions on where telehealth could or couldn't be deployed. Now telehealth is sort of allowed to be widely deployed in a whole number of states, and I would refer people to the CMS webpage, as well as to their, and of course the ASAM coronavirus public health emergency webpage, as well as their own state health and human services departments to figure out how the 1115 waiver that the state may have gotten authorizes the provision of telehealth services and the payment for telehealth services in a number of now novel situations in the context of coronavirus. I live in California, so our 1135 waiver is now permitting us to waive a whole number of in-person requirements for specialty SUD treatment and to deliver care through audiovisual synchronous telehealth platforms. Next slide, please. Additionally, Health and Human Services has now issued guidance that, this is the DEA and SAMHSA have issued guidance that an in-person medical visit is no longer required before issuing a prescription for a controlled substance. And both the DEA and SAMHSA have now clarified that buprenorphine, which is a Schedule III medication that is FDA approved to treat opioid use disorder, is specifically permitted to be initiated follow a synchronous telephone call and does not require a visual telehealth component. So the rules around how to initiate buprenorphine treatment for opioid use disorder are much more flexible than they were prior to the coronavirus public health emergency. Next slide. And the Health and Human Services has now issued that there's been a relaxation in the enforcement of HIPAA, or which are federal privacy rules, permitting us to use now remote technologies that weren't permissible before. So there's a whole number of platforms that have what are called HIPAA compliance rules that typically require a business affiliation agreement with the vendor of that telehealth platform in order to be able to do healthcare that is compliant with HIPAA through that platform. A number of those rules that still exist, the enforcement of those rules is being sort of temporarily relaxed during the coronavirus pandemic. Next slide. So just to be very concrete, and this, by the way, is not, I'm not trying to endorse any particular telehealth platform. So to be very concrete about what I'm talking about. So there's a whole number of HIPAA compliant options that I've listed in the column on the left side of the screen. Many of the vendors that are listed there have what they'll sort of sell are non-HIPAA compliant versions. So some of these actually have sort of more limited functionality free versions, and as you buy licensing of escalating costs, typically you get more functionality, and an element of more functionality is that at some point you can get the vendor to sign a business affiliation agreement to remain HIPAA compliant. And so although the vendors, again, on the left side of the screen, offer HIPAA compliant options, HHS has essentially said you can use these platforms even if you don't have a business affiliation agreement that secured HIPAA compliance, that you can use a number of these platforms to conduct telehealth visits, even if you don't have a business affiliation agreement on file. And then there's also allowable, really non-HIPAA compliant options that typically don't offer HIPAA compliance. And they've listed those in the column on the right that are specifically enumerated and now allowed to be used even in the absence of there being a HIPAA compliant version of these platforms. Next slide. What Health and Human Services has clarified is there are still audiovisual options, typically through social media, that are not permitted to be used for healthcare, particularly options where the audiovisual component is broadcast to a wide audience as opposed to secured between two individuals. And so what I've listed here is a set of telehealth platforms that HHS has said, even despite a relaxation of the enforcement of HIPAA compliance, there are certain things that remain not permitted, particularly audiovisual platforms that can't be secured. Next slide. So, I know I've learned a lot around the delivery of care as an addiction physician here in Los Angeles, and I've watched my colleagues in my community, many of whom, were sort of thinking about telehealth, but didn't necessarily have a telehealth strategy in their organization, rapidly figure out how to make telehealth a part of their practice, because in the context of the coronavirus public health emergency, in-person visits are now a more risky thing to conduct. So to effectively execute a telehealth strategy, and particularly how to extend addiction treatment to patients, you have to factor in actually the patient's ability and familiarity with the technology platform. I know, so I work, again, large municipal health system, the LA County Department of Health Services, and while we are, in the process of rolling out our own telesession or a telehealth solution, not all of our patients are equivalently savvy and equivalently equipped with technology to be able to access it. So you have to factor in, what are my patients? Are they able to navigate things like smartphones? Are they able to navigate things like laptops? Do they have access to those kinds of resources? I treat a generally under-resourced community that generally does not have reliable access to technology like smartphones and laptops where there are cameras and reliable internet access. So you do have to sort of factor that into then how do you deploy your technology platform. One other practical telehealth session approach is to confirm the identity and location of the patient and document that in a note. To obtain the phone number of the patient in case whatever technology platform fails. To obtain the patient's consent to participate in telehealth, I typically just document this. I don't necessarily require the patient to mail me something physically, but we discuss their consent and it's documented in the note. To arrange for any medically necessary follow-up. The standard of care really is the same, whether the care is delivered in person or via telemedicine. So the note should have essentially all of the same fields. It's not possible to conduct an in-person physical exam, but you can certainly comment on things like how a patient appeared or sounded based on the platform that you're using to take care of the patient. And services are rendered where the patient is located, not where the provider is. So the location of service is wherever the patient is. Next slide. So opioid treatment programs, which again, opioid treatment programs are licensed to administer methadone and buprenorphine products, and now in many states now, naltrexone long-acting injection to patients, have had to pivot. I think Dr. Clark, that's a excellent verb to describe what people are now doing. So opioid treatment programs are now needing to pivot to how do you deliver care when the traditional in-person, dosing of medication like methadone or buprenorphine, when the in-person component of that has an escalated risk of contributing to the spread of coronavirus, or novel coronavirus. So the guidance right now for opioid treatment programs is that it's critically important to remain open and available, right? Because we expect that there's going to be more demand for addiction treatment services, and particularly opiate treatment services in general, that opiate treatment programs are a core bedrock of offering opiate treatment services. And so that SAMHSA right now has issued guidance that there's flexibility in how OTPs are now able to do take-home doses. This is relevant to which medications you select, because there's ways of delivering, say, buprenorphine treatment outside of an OTP context that are more flexible than, say, methadone for opiate use disorder. making judicious determinations of when it's worth actually bringing a patient in for an in-person visit. So there's a whole number, actually there's a whole set of resources on the ASAM coronavirus website related to opiate treatment programs. So I'd encourage those that work in OTPs or those that seek OTP services to look at the most current guidance. And I know for, at least in LA County, we're now working with a number of the county contracted opiate treatment programs to do things like, deliver a set of take-home doses, which is traditionally restricted for people who've been in OTPs for a certain amount of time, who've demonstrated a certain amount of clinical stability. To even patients that don't meet those criteria are issued take-home doses to reduce the frequency with which that patient necessarily needs to continue to return to the OTP in light of, oftentimes requirements to shelter in place, and particularly for patients who themselves have been exposed to COVID-19 or who are, symptomatic with COVID-19, it's important to be able to coordinate OTP access for those members of our communities. Next slide. With access to buprenorphine, telehealth, I think, has been, particularly now, the waiver of the requirement for an initial in-person visit has now made a whole number of novel ways of delivering buprenorphine services to people with opioid use disorder much wider. And so now, in LA, and I'll sort of cover this in a later slide, in Los Angeles, we've set up a county-wide on-call consultation line, and it's staffed with providers 24/7 that allows us to initiate medications for opioid use disorder in consultation with another provider and with the patient on the phone. So that is had a significant impact on extending our access to buprenorphine treatment. That also means doing things like more extended prescriptions that we would typically do, and offering refills in case there's limitations on the patients being able to consistently adhere to what a traditional in-person treatment plan would be. We're now pivoting to deliver a lot of psychosocial treatment through telehealth and ensuring patients have an adequate buprenorphine supply. So the rule of thumb that we've been exercising in LA is, when you have a patient that, say, you're just starting and you would have typically written, say, a week or two prescription for buprenorphine, with or without a refill, we're now saying plan to double that, right? So a patient you would typically given a week, get 2 weeks, and a patient that you may or may not have given a refill, you can typically now offer a refill that the patient could go get delivered or picked up at the pharmacy, with the idea of you want to be sure that patients have access to buprenorphine. Extra buprenorphine in this context does have the risk of diversion and does have the risk of people overtaking prescription medication, but the risk of being without buprenorphine, which sort of make a point I alluded to earlier with opiate treatment programs, the risk of being without opiate treatment services is relapse, overdose, and death. And so the risk benefit during the context of the coronavirus public health emergency oftentimes favors and supports us offering more extended durations of treatment. Next slide, or of medication access. And then when it comes to the other medications for addiction treatment, like naltrexone long-acting injection, I know there's a number of clinics that are now pivoted to delivering sort of naltrexone as a long-acting injection to minimize the patients sort of need to go back and forth to the pharmacy. In cases where it's risky to do an in-person administration of an intramuscular injection of naltrexone, there are some clinics in the community that are converting patients to oral naltrexone with close follow-up so that the patient can be administered naltrexone long-acting injection when it's safe to do so. There's also long-acting versions of buprenorphine, injectable versions of buprenorphine that can also be used sort of similarly, that you can sort of bridge patients with sublingual dosing until it's safe to administer long-acting injectable versions of medications for addiction treatment. On the ASAM coronavirus website, there's a whole number of resources around ambulatory withdrawal management and around dosages and formulations of smoking cessation medications. Next slide. And I won't go through all of these today, but I've sort of alluded to, there's a whole number of federal policies that have shifted. The ASAM coronavirus website has a whole list of all of these federal policy changes that have a big impact on now extending availability of addiction treatment. Next slide. Dr. Clark again alluded to sort of pivoting. Oftentimes, those of us who work in public health settings are left to implement guidance on the ground. And in situations where we're, not typically used to or comfortable with strategy, the large health systems have had to adapt very rapidly, again, without a lot of guidelines, but instead with, using expert guidance. And so, providers are now dealing with situations and balancing difficult choices with, again, not a lot of evidence. But some main principles to consider are the stability and safety of patients, to make sure patients have access to medications for addiction treatment. There's oftentimes not an absolute requirement around testing during the in-person testing during the coronavirus public health emergency, and opportunities to do remote testing. So there are, I know now, technology vendors that are offering strategies to help people do testing, say through a telehealth platform rather than requiring the patient to come in person to a lab. And while diversion always remains a concern for most medications for addiction treatment, during the coronavirus public health emergency, the usual risk of diversion, you want to balance that against, okay, vote for the alternatives to bring a patient in for an in-person visit. What's the risk of that then contributing to the spread of coronavirus? So the usual rule of thumb is, while diversion always remains a risk and a consideration, that you want to balance that against the risk of, let's say you need to bring a patient in. Next slide. So in LA County, we've had, now the rapid deployment of expected practice guidelines. We've ASAM released an alcohol withdrawal guideline that we rapidly put into an expected practice, which is our sort of version of an internal working policy. And our expected practice is now published and uses both a combination of benzodiazepine, but also of anticonvulsant-based medication strategies to help patients who may not have access to alcohol and are likely to experience alcohol withdrawal syndrome manage that. We've developed a sort of countywide on-call line for addiction medicine consultation. LA County sort of regrettably boasts, I think, the nation's largest population of people experiencing homelessness who are not sheltered. And so we've had to now rapidly build these field shelters, as well as hotel and field quarantine and isolation sites for people who are symptomatic, for people who are experiencing homelessness, and pivoting most of our routine healthcare to televisits. And we're in the process of trying to install a telehealth platform that will work with our patient population. Next slide. This is what one of our expected practices look like, that goes through sort of alcohol use disorder management, as well as alcohol withdrawal management using anticonvulsants, as well as when to escalate somebody to like a benzodiazepine treatment. And with that, I think I'm going to turn it over to Dr. Bundy. So next slide.
Good morning, everyone. Thank you. Thank you, Brian. That was a lot of great material to cover in a very short time. The transition here, in the part that I'd like to talk about today, is really the integration, if you will, of informal support with formal support and medical treatment systems. Next slide, please. The COVID epidemic has created unprecedented challenges and also opportunities with regard to addiction treatment. Addiction treatment is best deployed under a model of chronic disease management. And in that model, patients typically start out with high levels of formal care and formal medical treatment. In addition, they are beginning to learn and change health-related behaviors, and that happens through informal systems of care and support systems. It's critical during this time that patients be able to access that and begin to incorporate informal systems and self-care management strategies to complement traditional formal medical care. COVID has led to isolation for us all, and in that isolation, we've been challenged with a number of issues that I don't need to reiterate here. But all of those challenges that we're facing, whether we have addiction or not, are underscored or highlighted in an individual who is trying to recover from a substance use disorder. I think what I've really been impressed by is, necessity being the mother of invention, and seeing the way in which the medical community and the healthcare community has really, like good jazz improvisation, we have excellent, smart people in the world who are doing this good work, and while there's uncertainty and discomfort in challenging our assumptions and our existing paradigms, the situations like this give us an opportunity to rethink how we do things in a patient-centered way to potentially come out the backside of this with improved systems of care and improvements in patients' ability to access peer support. Whether we're talking about peer support for healthcare professionals with burnout, or peer support for individuals recovering from addiction, or peer support in combat trauma PTSD veterans in the veterans healthcare system, the power of shared experience is an incredible healing power. Next slide. What we saw, Washington was an early hot zone, if you will, for the COVID epidemic, and my offices went virtual on March 9th, and we've continued to operate virtually since then. We actually run 13 weekly monitoring groups around the state of Washington for healthcare professionals, and so we had an immediate challenge to develop those peer support mechanisms relatively quickly. But what I also saw was within about 2 weeks of that time, the entire recovery community had pivoted. And what was thought of as acceptable in terms of in-person meetings being highly preferred to online support, pretty soon everybody was getting online for recovery work. I think it's just really important for providers to support and encourage participation in mutual support groups, and you can develop materials and a proactive approach to ensuring that your patients have access to these services. The ASAM website on COVID-19 is really a one-stop shop where clinicians can direct patients and organizations can direct patients who need a wide range of resources. There's a meeting really for everyone. They're varied. There's 12-step based approaches. There's Buddhist-based recovery approaches. There are diverse pathway approaches that are all available, convenient, and accessible to patients. And one of the things that we've seen is that patients are actually attending more recovery support meetings because of the convenience of online access. Now, we have the same challenges in terms of patients' access to technology and a private environment in which to attend a meeting, and those types of issues need to be managed. But these online communities are very helpful in making sure their participants have the support they need and strategies to manage those. So it's really getting people plugged into the mutual support community and then allowing the community to take over in terms of helping individuals continue to access and be engaged in those programs. We heard a lot about privacy and security early on in Zoom bombings in the Zoom platform, and most of these are operating in the Zoom platform, with the exception of In the Rooms, which is there's a link to that at on the website at ASAM. In the Rooms has a community of over 640,000 people worldwide who are recovering, and they've had their own app and their own secure environment long before COVID. So if patients are particularly concerned about that, that is one of the resources that you could recommend. But there have been a lot of improvements in Zoom, and other platforms have really engaged around the issues of privacy, and there's a tremendous amount of guidance again on the ASAM website about measures to support privacy and security. Overall, I think that mutual support in the virtual environment will continue. It has really exploded in the context of COVID-19, and I suspect that this will offer enhanced access and alternatives for individuals who in some ways may struggle due to typical access issues, time, convenience, location. Those are barriers that have largely been removed, allowing people in various circumstances to be able to attend in-person recovery meetings. There's also while there are issues around the privacy and security and unwanted visitors that can be mitigated, I think that there is the opportunity for individuals to experience more different types of mutual support and to find their people in recovery because of the availability of the meetings and so many more meetings for people to choose from. And so I think it's an exciting time for all of us to see that in the post-pandemic phase that there will be increased resources available for peer support in the recovery community. Next slide. These are general recommendations. Really, I think organizations need to follow local public health guidance in terms of how we return to small group meetings, or when small group meetings can't be avoided. There's lots of guidance in there around managing the environment of care, sanitation, and so forth, and recommendations for how to conduct groups, small group meetings if absolutely needed. One of the things to consider is that the infrastructure that will help improve suppression of COVID-19 over time is widespread testing and contact tracing. So certainly for groups that are more in the more formal care arena, such as intensive outpatient and so on, having contact information goes without saying, but there may be a need in case of an outbreak in a healthcare setting for contact tracing. So having some information available to do that it can be helpful. Next slide. Again, the ASAM COVID site is your one-stop shop for other kinds of information that patients might need in order to feel more comfortable joining an online group, issues of etiquette and expectations and how to present oneself if they are new to online or any mutual support is available at the ASAM website. I think that concludes my section, and I will turn it over to our next speaker, Courtney Lavelle.
Hello, everyone. Next slide, please. I have an extra layer of empathy for individuals struggling with their substance use disorder during this pandemic. I am struck by a visceral memory of a 19-year-old version of myself. She was so alone. She was so isolated. That 19-year-old version had spent the majority of my life in some phase of survival mode. My sympathetic nervous system was always working. There always seemed to be ample amounts of cortisol pumping. I was always at the ready to defend off those early childhood traumas scarred into my gut and ready to attack from the inside out. That pervasive feeling of aloneness, of otherness, that feeling that something is just not right out in the world. It cultivated in me a void I was constantly trying to figure out how to fill. Overachieving, good grades, varsity sports, makeup, anxiety, an eating disorder, depression, self-harm, alcohol, marijuana, pills, heroin, nothing ever worked to fill that void. By 19 years old, those feelings finally consumed me. I had nowhere left to go. I had no hope my future would ever be without pain and destruction. I was tired of running from myself. At just 19 years old, I gave up. I tried to end my life by overdose on the side of a very rural country road, all alone with no one to find me. That seemed like the kindest thing I could do for myself at the time. Gratefully, my higher power had other plans for me. The next morning began the very bumpy, clumsy stumble into my recovery process that 12 years later is still evolving and growing. I've been working on quieting that rumbling gut of mine ever since. I've been deprogramming those unconscious belief systems and building up new ones that actually serve me. I am always trying to find ways to connect to others, shake off that aloneness, and understand there is no void within me swallowing me whole. Rather, intentional space in my heart to fill with self-love and acceptance. It's a process, and none of it is ever easy to do, especially early on when your brain, your gut, your every ounce of being is telling you that doing so will cause imminent doom. My heart feels so much for those struggling with addiction right now. Those in their active addiction, those in those early stages of recovery. I feel so deeply for those in early stages of change, trying to do things differently in spite of all of this. Those who do not have access to the same supports and coping skills they've been grasping onto. The social isolation for myself, 12 years later, it's hard for me. Not being able to hug on to my people, feel their warmth, sit in the energy of a good yoga class, it affects me. Imagine how much more so our people trying to change their deepest ingrained patterns are affected by all of this. Next slide, please. And our people are constantly being bombarded with messaging saying just how gloomy things are for them. Messages saying things like, this will take a long time to ever get back to normal, if ever at all. Or whether it says they have a call to their outpatient because they've got children at home, they're homeschooling and can't make it in for their one-on-one, which they might be their only adult interaction for a week or two or more. The appointment they've been waiting on so their therapist can help talk back that welling pit of anxiety that's growing. Or when they can't get a ride to get their next dose of methadone. Or when they're still active and they can't find someone else to use with to administer the Narcan they've been holding on to. As a side note, Canary is a great app to recommend to clients who are still active in their use. I recommend looking into that. Next slide, please. And what about our people with comorbidities? What about our people with lung conditions from smoking for years? Or endocarditis or abscesses? What about the great many of our people with weakened immune systems from the trauma they've endured over lifetimes? How are we prepared to care for them and their vulnerability now in this time of shift and moving forward into whatever the new normal is? I don't have that answer, but I'm counting on the collective to help figure it out, because we really don't know what the long-term implications are going to be of COVID-19 on our people. Next slide, please. What I do know is collectively, we're getting pretty darn good at embracing harm reduction. Even my awesome 4-year-old is working on it. He's so cute. As Dr. Clark covered in the underlying themes earlier, we must pivot from the traditional way of doing things. Our goals need not to be to get people to stop using their coping skills right now. Our goals could be, how can we help people build healthy, safe enough lives that they do not need their harmful coping skills in the same way? How can we help people build their support networks in a way that works for the reality of their life in this current landscape and not force them to conform to the ideas laid down decades ago? Next slide, please. Maybe there are gifts for practitioners in all of this. Prior to working as a recovery coach, I worked as an addiction counselor and outpatient. I see how strict we were in the delivery of our services and see a silver lining in all this adaptation we're faced with today. In some fellowship spaces I've spent time in, there's this idea of reflecting back over the things you've done in your life and inventorying them, good and bad. Maybe this pandemic and our world on pause is allowing our field an opportunity to do the exact same thing. Looking back, it's not all bad. There are gifts to rediscover. I'm sure some of you are familiar with the Caring Letters study. Between 1969 and 1974, psychiatric hospitals in San Francisco admitted over 3,000 people for depression and suicidal tendencies. psychiatrist Jerome Motto randomly assigned 843 of those patients to one of two groups after discharge. In a contact group, patients received handwritten letters from healthcare professionals they'd worked with. The letters expressed care and concern, like what you see on the screen. Patients in the contact group received 8 letters in the first year and 4 letters every year for the next 4 years, for a total of 24 letters over 5 years. Patients in the control group didn't receive any. 2 years after leaving the hospital, when at-risk patients are most likely to kill themselves, only 1.8% of patients in the contact group had committed suicide, compared to 3.52% of patients in the control group who hadn't received any letters. Even 13 years after hospital discharge, patients who had received letters from the hospital still had lower rates of suicide than those who hadn't received any letters. Next slide, please. Perhaps there's a lesson in this. The virtual landscape we're faced with today for our service delivery has proven to be a beautiful opportunity to practice giving our own caring letters. We're seeing this incredible harm reduction-esque shift in how we support our people. Truthfully, we might not have ever operated in a more trauma-informed way, and we are doing so right now by literally meeting people where they are at, in their homes, on their phones. Nearly around the clock virtual support groups of every kind are free and accessible to many, many more people. Next slide, please. And perhaps, or rather, hopefully, this might become the new normal. Not losing face-to-face interactions completely. That nonverbal communication is hard to get over a Zoom call, but adding to them all these caring layers to fill the voids in our service structures that have persisted for decades. The recovery coach in me is excited by my strength-based perspective, seeing opportunity for growth all around us in this pandemic. We are thriving in this virtual landscape. We're moving all of our training and education online. We're building our networks up in a way to meet our people wherever they may be when they are ready, willing, safe, and strong enough to make changes in spite of the things happening around us that we can't control. Next slide, please. I challenge us all to remember our newfound empathy for those who feel most alone, for those who feel most isolated, for those who are struggling with the quote unquote disease of isolation that addiction can often be, and figure out what our caring letters could be both today, in this current landscape, and in a post-pandemic world. I'm excited to hear some questions and grateful to be part of this. Thank you.
Well, thank you all. Terrific presentations from all of our panelists, and a lot of really interesting questions have come in as we've gone along. One of the things that has come in multiple times, people are wondering where they can find this. This has been recorded, is being recorded, and will be available within the next few days on both the National Academy of Medicine site and the American Society of Addiction Medicine website. While you're waiting those few days, there was a request, and if we could go back to slide, I think 30, around specific telehealth platforms. And I'm just going to say these because it is so important that people be able to utilize platforms very soon. And so for those of you who don't have access to the video, I'm just going to, as Dr. Hurley said, this is not an endorsement of any platform or a denouncing of any other platform, but just on the information which has been made available, those that HHS and et cetera have said are acceptable telehealth platforms. Can I go back up one? Thank you. Which these are HIPAA compliant options, often through business associate agreements and arrangements, so that HIPAA is codified. Those are things like Zoom, Skype, Microsoft Teams, Cisco WebEx meetings, GoToMeeting, BlueJeans, BC, and Doxy.me. Allowable but not HIPAA compliant platforms include Apple FaceTime, Facebook Messenger video chat, Google Hangouts video, and I'll just mention that the specific telehealth platforms that are not allowable, at least under the federal guidelines for billable appropriate care, currently are Instagram Live, Facebook Live, Twitch, TikTok, and their equivalents. So sorry for reading you slides, but for those of you who are not on video, it's important that you get that information currently before we get this up on the website. So now I would like to make a kind of some statements out to our panelists and hear what they're thinking and what they've experienced and heard about in the field on these issues. And not surprisingly, there are issues that have come up as questions that are clinical issues. There are issues that have come up that are regulatory requirement issues. There are issues that are payment issue. There are issues that are around specific technologies and how to utilize those, and what to do when people can't access a wide range of technologies because of the social services that they have resources available to them, and the restrictions under COVID. So I'm just going to start off with something around stigma, which is there's a question about in one geographic area that inpatient beds to treat people with addictive disease are being cut in order to presumably increase social distancing, so the same physical space used for less people, while that's not occurring even in psychiatric or mental health settings. So wondering what experiences you have had or what you have heard about in terms of not only just substance use disorders versus psychiatric care, but substance use disorders versus medical care in terms of triaging medical resources during this time. And anyone like to take that to start is fine.
So this is Brian. I can speak to the guidance that we've gotten from our County Department of Public Health in Los Angeles, which is the county department that contracts out for specialty SUD care, including residential SUD care. So ASAM 3.0 levels of care and upward. There is actually some very concrete guidance over things like how far beds can be from each other, how you can position patients to sort of minimize the spread of coronavirus. And I do know that as you increase the amount of space between beds, that then limits sort of overall capacity. And again, I'm not aware of that parallel conversation necessarily happening in the general med surg units or in the non-addiction inpatient psychiatric services. In general medical settings or in inpatient psychiatric settings, oftentimes what we're doing is cohorting, right? So patients with known exposure are being cohorted with other patients with known exposure. Patients without are being cohorted without, but there's not necessarily this sort of like space division that's happening. And so, so I do wonder of whether or not so space limitations are going to impact the availability of residential addiction treatment services. That said, at least in the county where I work, the guidance from our County Department of Public Health has said, when feasible, because there is the acknowledgement of you want to balance protecting people against the transmission of coronavirus against the people need treatment, right? Like people still have health conditions and still need treatment. And so, when it's not feasible for all those limitations to be in place, there's still principles around sort of hygiene and how you can, structure things like groups and beds to minimize the spread of coronavirus, even if you can't necessarily maintain, say, 6 feet of distance between, exactly the way that might be recommended in theory.
And I've heard, Kelly, what's interesting to me is that the question sort of even arises, going to your comment about stigma. I hear medical directors of inpatient and residential, even partial hospital programs, talking about having discussions with administration about whether they should stay open during this time, as though addiction treatment is somehow elective. And going, I was really, Courtney's comments were, very powerful, because to be a person who is struggling with addiction and wanting access to those services and wanting to stop, from that perspective, to be told that you're wanting to stop and the services that you need might be elective, is really to not understand what it's like to be suffering with addiction.
Courtney, have you, don't want to put you on the spot here, but have you heard from the field any specific kinds of instances of stigma around people accessing addiction care that are different than their ability to access other types of care right now?
Oh, goodness, yes. I think the one that's pressing most heavily on me are those individuals who are receiving methadone treatment, and the hoops and regulations that they have to jump through in order to be able to even access getting to the methadone clinic to receive their daily doses, and the criteria around when they're considered quote unquote stable enough to have take-home doses is just so strict in general, but especially in today's world where functioning that highly in society is hard for most of us, let alone those with active addiction. So I know I've heard of many cases of individuals on methadone right now who can't receive their doses, who their clinicians are not adapting, they're not willing to follow guidelines because they're not recommendations yet. They're not regulations, I'm sorry, yet. They're just guidelines on how we can bring home take-home doses. If this were somebody struggling with diabetes, type 2 diabetes, and they were eating extra sugary foods to cope with their stress and anxiety in this time, we wouldn't start holding back their insulin or waiving their behaviors over them as a punishment to get their medication. But yet I still see this persisting in the addiction treatment world.
I think you bring up a very good point here. What you're talking about is really an illustration of a lot of the variation between states. The federal government, SAMHSA, has come forward in terms of methadone and said for patients who are stable, a state opioid treatment authority can request for the state a blanket exemption from the normal phasing up for take-homes and get to 28 days for stable patients and up to 14 days for those who are less stable but considered by the physician to be safe with those take-homes. But that's not a requirement. That does require buy-in from the state. And I think that leads us into a couple of other questions that have come forward around telemedicine. One around prescribing of the numbers of days of prescription. There's a question here from New Mexico stating that apparently they've got some internal to the state regulation that only 10 days of initial buprenorphine can be prescribed without refills. And other questions here around payment and what is allowed under payment. And payment for Medicare, that's been pretty clear and continuing to evolve with really excellent ability for providers, clinicians to bill for straight Medicare. But Medicaid, always being very state specific, leads to another issue. So, and also true within commercial plans within each state. Is telemedicine being paid for at substantially less than regular rates, at equal to regular rates, at greater than regular rates, or at not at all? So that sort of state variation, I'm wondering specifically around not just prescribing, but around just telemedicine in general. What you've each sort of experienced or heard about in terms of the range that's out there. And then if possible, what you've heard people have been able to do to try to move states forward during this time.
This is Brian. I live and work in California, and I'm very lucky that California was, one of the initial states to get 1135 waiver. It's reimbursing for telehealth visits at the same rate as in-person visits, at least at this point. All of this, of course, is subject to change, right? Because this is a rapidly evolving sort of policy environment. But at this point, our community health centers and our safety net is able to access and draw down Medi-Cal, which is our state Medicaid program, Medi-Cal resources to be able to support our telehealth programs. And our state, covers up to 24 milligrams of buprenorphine a day, and up to 30 days at a time. So we're not limited, and you're able to write refills. So the comment about 10 days with no refills, I don't know to what extent. I don't practice in New Mexico, so I'm not in a position to kind of opine on that. But I will say that I'm lucky to live in a state where sort of reasonable access to medication services, whether it's sort of into a general health setting, to a special addiction treatment setting, has been has rapidly shifted to be permitted. And we haven't had a lot of restrictions on, the duration of, what would be a reasonable duration of prescriptions that we're able to offer, and we're able to get paid for the work that we're doing. So at least in California, we've been fortunate.
Yeah, the meta issue here is, how do we coordinate and collaborate with many different systems? And the shameless plug here is, associations and membership involvement through organizations like NAM and ASAM, and even my organization. I'm the current president of the Federation of State Physician Health Programs. And, we had to adapt very rapidly to this dynamic environment. There was actually a question on the about how do we monitor health professionals under these circumstances, and the answer is we don't know. We have been figuring it out, but I think the worst thing is the old saw of don't worry alone. Who can you reach out to? Not what will we do, but who will we do it with? And how can we find out what states are doing in California, like California, if you're in New Mexico, so that you can then take that to your stakeholders and say, this is working in another location and here's how they're doing it. Maybe we could do something like that here.
Okay. I think that is one thing actually that ASAM's been doing, utilizing the Chapters Council, is regions are getting together and talking about what they've done in their states, where they've had problems within the states, how they've brought together stakeholders to address issues, because sometimes all it takes is 5 words inserted into something from, the state Medicaid director or the state opioid treatment provider or someone like that, to allow for care to be happening in the way we need it to happen. And so excellent point on, don't worry alone, and learn from peers here on this. There's a number of questions here about different kinds of ways to keep in contact that aren't really like telemedicine, which is the traditional, and much of what we're doing now is not traditional telemedicine. And we'll see what happens when we no longer have the crisis, if whether some of this audio-visual, virtual sessions will be allowed to go forward or not. But also around things that are, digital monitoring devices, digital therapies, medical monitoring types of programs, even questions about how do you do that? How do you can't get vital signs over telemedicine, although you might be able to see goosebumps, those sorts of things as you're trying to look for withdrawal. So have you seen or heard any technologies that, or clinical pearls that, or things that you've just heard people are utilizing to help with connectedness that are outside of the realm of standard medical practice, or standard, everything here is outside of the realm of standard medical practice, or standard peer support? So I'll just throw that open to you for interesting things you've seen or heard, or any pearls you might like to share.
I'll jump on that first. I think the recovery community and world has always been a bit more forward thinking about finding adaptations and ways to deliver services. I know recovery coaching, recovery peer advocacy spaces, we've been working digitally for a while now. There's a lot of great emerging apps and software and groups trying to offer both 12-step and non-12-step based recovery supports through things like Zoom meetings, through their own platforms. There's been quite a bit of action, I think, not just during this pandemic, but prior to the pandemic, which positioned the recovery world to adapt really quickly. There's also a lot of opportunity for recovery peer supports to kind of grow. I see one of the questions here is there a way to add recovery peer supports in other levels in healthcare settings? I know insurance providers are starting to bring more peer supports onto staff, offering call-in virtual meetings for substance use disorder patients to receive virtual supports. My hope is that as we continue to adapt and create a new normal in this pandemic, in the post-pandemic world, we can keep these changes and do a bit of research on how some of the outcomes of individuals who've been able to access support more remotely.
All right, thanks.
Yeah, I think it's a good argument for, bringing peer support formally into the treatment environment, and being able to create, a lot of questions about, I work with a disadvantaged population. They don't have access even to broadband internet or mobile technology for accessing peer support. And, just ideas come to mind of, using peer support specialists and creating socially distanced environments where, care providers can actually make the technology available. I mean, there are over 1,000 virtual meetings going on, in any given week nationally, that would be easily integrated into a clinic schedule where you could, have small groups of people appropriately distanced who could, be watching, could be potentially participating in online support and getting together. So there's just, it's really interesting just to think about all the different ideas that people are having out there. But I agree with Courtney in the fact that the recovery community is a highly adaptable, resilient community. It's really just getting people plugged in, and then people take care of each other, which is a huge advantage that we have in addiction treatment, is utilizing that recovery community.
Kelly, I was thinking of some of my patients that I've been trying to get to go to meetings forever are now that they can do it and sort of participate in a structured meeting from home makes all the difference, right? And I sort of think the deployment of a lot of these, virtual technologies is having reach literally into patients' homes in a way that's different. I think that point has been sort of made earlier. I also think that there are some of my patients who really do who miss the in-person component, right? Like that don't find that the telehealth platforms are just the same, right? They're like, it's just not the same, right? So it doesn't feel the same. So what I think we're seeing is a shifting, right? It's not so much that these platforms are necessarily a better way of delivering care. It's so much sort of it's a different way of delivering care. And I think how you're able to meet the needs of patients in this new context where you want to limit in-person visits will mean that some patients are going to need additional support. And then you mentioned, using telehealth platforms, it's tough to do a complete physical exam, and that's absolutely true. But you can still do a pupillary exam, right? It's not a full exam, but you can still get a patient's eye pretty close to the camera. And so there's still elements, particularly around withdrawal management, that you can assess. And the last thing I'll throw out is, there are some technologies where people are doing saliva testing, putting a cartridge soaked in saliva into an immunoassay reader, and then looking at the color change on the reader itself, that are a way of doing sort of remote toxicology testing. And ASAM has an entire sort of document around drug testing. I'm not going to sort of rehash the whole thing, but I will say for carefully selected patients where it's important to get toxicology information, particularly around sort of testing, but where the risk of bringing that patient in for an in-person visit, there are now ways, you sort of mentioned pearls. Well, there are ways to get some information, with all of its imperfections and sort of, caveats. There are ways of doing that through a telehealth platform that don't necessarily require a patient to come in for an in-person test.
I would like to add, though,
Sure,
there are some huge challenges, especially for those with lower socioeconomic status, having access to cell phones and technology and the minutes on their cell phone to receive these services, having access to internet. I live in upstate New York, and it very quickly becomes very rural, and internet connection can be spotty at best. And I have seen peers drive out to some of these rural areas and set up hotspots. And although they're still maintaining social distancing, they've put out their announcements and letting the local community know that you can come to these specific spots where they have their hotspot active and receive your telehealth during a certain time period, which is amazing and incredible, and the lengths that peer service providers will go to help their peers, but some of the challenges that we're still going to find even while we're trying to adapt.
Courtney, that's a great point. In LA, we have a whole number of community health workers and street outreach teams to sort of like help facilitate that level of connectivity for people experiencing homelessness in a way that is really innovative, really important. So I just want to highlight, yes, absolutely, that the role of peers going to where people are. This message of you try to want to get treatment where people are is vitally important, particularly when access to technology. There's not always people can't always access these sort of technology platforms that they would need to stay connected.
We had access issues in the old world. I mean, we're not suggesting that telehealth and virtual reality is the answer to all your problems today. I think what we're recognizing is that it's creating opportunities that didn't exist before. If the choice is, a pupillary exam over the mobile phone versus not seeing the patient at all, which might have been the option in the future because they wouldn't come in because they didn't have gas money or transportation to the appointment. We're just really, it's very just exciting, I think, to think about how this augments our ability to connect formally and informally, in treatment and out of treatment. It's very exciting.
And I think you've all done a great job of illustrating some of those themes that we talked about earlier in terms of it's a different world. We don't have access to the normal resources. And there are a lot of questions that have come in that are sort of clinical questions about what do I do because I can't do X or I can't do Y. And some of that is there isn't an answer for that. There isn't a single best practice for that. If you're a clinician, you use your best clinical judgment with all of the clinical resources that are available to you in your community for that patient and in your community, which is something that's new and different for clinicians. And at the same time, that pulling together as a community and breaking down silos and finding ways to get those hotspots out there and say, I can, come here and you can connect, are the things that we're all going to have to do as we're moving forward here. We've got just a few minutes left and certainly a lot of questions. But what I'd like to do is give you each a minute to say what kind of take-home message around this issue of connectedness and access to treatment and support would you like folks to walk away from this webinar with? And so, Chris, let me start with you.
I guess everything's, kind of always a risk-benefit analysis, and, results may vary. I want people to give themselves a break. Everybody's doing the best that they can under the circumstances. It's stressful for the caregivers. I know ASAM is working on this Federation of State Physician Health Programs, is putting together resources as well for people who are just trying to do the best they can under the circumstances to care for their patients and for each other. And I think, what I'd like to, encourage is that we take care of each other, and we also give ourselves permission to begin to rethink some of what we think of traditionally, whether it's in terms of testing to monitoring illicit use of culprit substances, those kinds of things. We can relax a little bit. People want to get well, and we need to create the supports that are necessary. And we've been able to, modify monitoring requirements for health professionals and work with and be flexible around that. And we haven't seen, a massive rush to relapse and some of the catastrophe that we expect. Sometimes in a world that's dominated by somewhat conventional wisdom, some part dogma, some part familiarity with what we do and being comfortable with that. And I think this is challenging all that and giving us both individual opportunities to expand our thinking, also giving our patients more opportunities to do well in recovery.
Thanks, Brian.
So Chris used the word relaxed, and I think that would, if I had a theme, it would be that. You know, we typically think of the frame of connecting people to treatment as, you know, we have a set of services, and then we have a set of expectations for the patients that we're privileged to serve. And typically those things mean, you know, patients come in for appointments, and there's testing, and there's you know, a whole sort of set of services that and expectations that we have for them. You know, Chris mentioned, you know, wanting to make an individualized and contextualized risk-benefit decision around when does the patient need to come in and when to not. And so this means sort of relaxing things, like relaxing how frequently we would do testing, or relaxing the methods with which we do testing, you know, rather than, you know, being very stringent about you get exactly this much medication, you have to check in at exactly this time, say, you know what, it's coronavirus public health emergency, like we can be a little bit more relaxed in sort of things like prescription duration and visit frequency to accommodate that people are in a really different situation, and then to innovate around how we reach out to patients, because, you know, telephone visits, telehealth visits, and in-person visits are now actually all three legitimate ways of initiating and continuing patients with treatment. So leverage the flexibility we have now in with regulatory and reimbursement for these ways of delivering care to people. So take advantage of that regulatory flexibility and reimbursement in order to be able to reach out to patients in ways that are new and innovative.
Great, great. And finally, Courtney?
Goodness, what they both said. And I will just highlight I think the really cool analogy that exists right now between how we're responding to COVID-19 and how we traditionally have responded to substance use disorder. I mean, with the picture with my son, every time you go to put on that mask, you are not putting on that mask to cure COVID-19. You are putting on that mask as a harm reduction technique to keep yourself safe and to help keep other people safe. The end goal is not to solve the issue immediately by taking this one action. It's to lessen the harm that could come. And we can adopt that a lot into the way that we treat people with substance use disorder and who are in active addiction. I know a lot of us would love to wave our hands right now and make COVID-19 just disappear and be gone. And it can be scary looking at what we're facing and what we have to deal with and what we have to conform to and adapt to. It can be overwhelming, and our fear-based reaction is just wanting to make it go away. And that is the same thing that we often do as caretakers, as family members, as loved ones, as doctors, as clinicians. We want to just wave our hands and make substance use disorder disappear in our clients and our family members and in our friends. And that is just not the reality. That doesn't happen that way. And that is not necessarily a bad thing or a good thing. It just is. And if instead we try to focus in on the harm reduction pieces, the little things that we can have control over, the little positive impacts that we can make, and we put those on the pedestal, those are the big wins, no matter how small they are. It helps us to relax. It helps us to breathe deeper. It takes some of the pressure off, and it can be some of the most supportive approaches we can give to people who are struggling.
Wonderful, thank you. Well, I'd like to thank the panel and for a terrific session here, and like to hand this over to Liz to end our webinar.
Thanks so much, Kelly, and really to all of our panelists. This has been an immensely informative and powerful session, and I can't thank you all enough for taking time out of your busy schedules to join us today. And I think this has been a very helpful and informative session for our participants, given all the activity over the course of the past 90 minutes, which really flew by. So again, thank you to all of you. I'd also like to extend our special thanks to ASAM, who've been terrific colleagues and partners in organizing this webinar, as well as our forthcoming webinars. And of course, thank you to all of our webinar attendees for participating and taking the time today to join us. As a final reminder, this webinar has been recorded. You can find the webinar recording, the speaker slides, as well as information on continuing education credits and more at nam.edu/treatment webinars. And again, just a final thanks for your participation today. Please stay safe, stay well, and enjoy the rest of your day. Thanks, everyone.
Thank you.